മരിയൻ മണി 7:35 ഹലോ മരിയൻ, ഗുഡ് ഈവനിങ്.
സർ കേൾക്കാമല്ലേ?
അല്ല, അപ്പോ അല്ല 7:35 ആയി അല്ലേ? മറ്റേ എലിസബത്ത് ഇല്ല എന്ന് പറഞ്ഞോ?
എന്നോടൊന്നും ആരും ഒന്നും കമ്മ്യൂണിക്കേറ്റ് ചെയ്തിട്ടില്ല.
കഴിഞ്ഞവണേ എലിസബത്ത് ഇല്ലായിരുന്നു. അപ്പോ എലിസബത്ത് ഇല്ലായിരുന്നോണ്ട് അപ്പോ കഴിഞ്ഞവണ നമ്മുടെ നടാഷിയായിരുന്നു ഗുരു. എലിസബത്ത് വരത്തില്ല. ഇപ്പൊ എലിസബത്ത് ഗ്രൂപ്പിൽ ഇല്ലല്ലോ, ഉണ്ടോ?
ഇല്ല, ഈ ഗ്രൂപ്പിൽ ഇല്ല. ഐ തിങ്ക് ഷീ ഹാസ് നോട്ട് ജോയിൻഡ്. ഇല്ല.
ബാക്കിയെല്ലാം അങ്ങനെയാണെങ്കിൽ എനിക്കൊന്ന് പ്രോബ്ലി ഇപ്പൊ 14 പാർട്ടിസിപ്പൻസ് ആയി. ഇപ്പോ 14-15 ആയി. അപ്പൊ അങ്ങനെയാണെങ്കിൽ പ്രോബ്ലി യു ക്യാൻ ഇൻട്രൊഡ്യൂസ് യുവർ സെൽഫ് ആൻഡ് ആൾസോ ശിഷ്യ എവിടെയാണെന്നുള്ള കാര്യം നമ്മൾ പറഞ്ഞിട്ടേ പ്രോബ്ലി വിൽ സ്റ്റാർട്ട് അല്ലേ? 7:35 ആയി.
Yeah, sir. We'll start off. Okay. Yeah, dear all, good afternoon, good evening. Myself, Dr. Marian. I work in RIO Institute as oculoplastic consultant. I did my PG actually from RIO, so I'm an RIO alumni, proud to be an RIO alumni. Today my Shishya is Dr. Sheba. She is also from RIO Trivandrum. I think we will start the case discussion.
Hello.
Yeah, can start presenting the case.
Good evening, everyone. Patient's name is Violet, a female patient, age 65 years, coming from.
Slide show ആണോ കിടക്കുന്നേ? Slide show അല്ലല്ലോ.
Can you make it into full screen?
Madam.
Yeah, now it is correct.
Patient's name is Violet, female patient of age 65 years from Punalur. She's a homemaker. Present complaints are complaints of swelling below left lower eyelid, noticed 3 years back, and complaints of sudden increase in the same swelling of 6 months duration. History of presenting complaints. Patient was apparently normal when she noticed a swelling below left lower eyelid 3 years back. Initially, it was small in size. Then patient noticed a sudden increase in the size for the past 6 months. It was associated with itching. No history of pain or the swelling discharge. No history of loss of weight or loss of appetite. No history of any other swellings noted anywhere else in the body. No history of similar complaints in past or in the family members. Past history. No history of complaints in
Dr. Shiva, can you stop with the first slide? So can you just go back to the first slide? Yeah. So now you're going to the past history, no? So from the history of presenting complaints, what is your inference? Why did you ask history of pain over the swelling discharge?
If the neural tissues are, if there is pain, then it could be an inflammatory or infective in nature.
Yeah, which can you be little specific? Which infection or inspection that is persisting for 3 years, and then it is gradually since last 6 months it is increasing? Can you think of something?
Cutaneous, sebaceous.
Yeah, yes. So sebaceous cell carcinoma sometimes, it starts as a small chalazion to start with. So it will be like, without pain for some time, and all of a sudden it starts increasing in size. So it can be a sebaceous tumor. Then why no history of any loss of weight or loss of appetite?
If it is a systemic spread is there or metastasis is there, then loss of weight, signs of malignancy like loss of weight or loss of appetite. For that, it was smell.
Okay, so one more thing which I wanted to add, like some patients will already have some problem, and this can be a secondary problem. So this is like, the patient is otherwise a healthy person, no? Yeah, okay. So why did you ask no history of any other swelling noted anywhere else?
Because to rule out metastasis, also multiple basal cell carcinomas are associated syndromes. And
how you know? I mean, so one is multiple. Basically, you have to be no pigmental lesions, like no nevus, nothing. Then there are some neurocutaneous tumors, neurofibromas. Okay.
Okay.
Yeah. So from the history, now what you infer now?
A lower lid tumor is present. There is chance of malignancy because of the sudden increase in size.
Yeah. Okay. Fine. So yeah, come to the past history. Yeah. Just move forward.
Okay. Past history, no history of similar complaints in the past. History of hypertension for 6 years on TAM amlodipine 5 mg and history of dyslipidemia for past 6 years on TAB atorvastatin 20 mg night time.
Just stop. I mean, I would like to know some few other things also. So from the history, now we are dealing with something persisted for 3 years and started increasing since last 6 months. So past history, anything would you like to add?
Madam, history of radiation.
Yeah.
exposure.
So from which is very, very important. Like which tumor? I mean, if you can think of which tumor, history of radiation in the where?
In the head and neck region.
Yes, exactly. History of radiation in the head and neck region predisposes to
Lymphoma or
yes.
cutaneous and basal cell carcinoma and cutaneous malignancy can also come from
Yes.
irradiation.
All tumors can come, basal cell, squamous cell, then lymphomas, or everything can come. Anything else?
Lymphoma and
Yeah, that we have already discussed. No past history of any radiation in the past. So any drugs which you like to specifically actually now there is lots of patients on immunosuppressants. Solid organ transplants are very common nowadays. So they are all on immunosuppressants. So patients on immunosuppressants can have periocular tumors, periocular malignancies especially. So that also better to ask. Okay. Then let's move forward.
Family history, no history of malignancies in the family. Coming to the personal history, non-veg diet, normal appetite, no history of weight loss, no alteration of bowel and bladder habits, no addictions. General physical examination. Patient is conscious, cooperative, well-oriented in time, place, and person, moderately built and nourished, no pallor, icterus, cyanosis, clubbing, generalized lymphadenopathy or periodal edema. Coming to the vitals, pulse rate 76 beats per minute, normal in rhythm, volume, character, and condition of vessel wall. Blood pressure 130, 80 millimeters mercury measured from right arm in supine position. Temperature febrile, respiratory rate 14 per minute. Systemic examination, central nervous system examination, higher mental function was normal, no focal neurological deficit. Cardiovascular system S1 and S2 heard, no murmurs. GAT per abdomen soft, no tender, no organomegaly, bowel sounds present. Respiratory system, normal vesicular breath sounds heard bilaterally and no audit sounds. Head and neck examination, no evidence of other premalignant lesions or malignant skin lesions, no enlarged preauricular, submandibular, or submental lymph nodes, no scars from previous biopsy, radiation therapy, surgery, or trauma.
Yeah, just stop this. Yeah, you are good only. No evidence of any other pre-malignant lesions or malignant skin lesions. What did you specifically look for?
Pre-malignant lesions like actinic keratosis or xeroderma pigmentosa.
Yeah, xeroderma pigmentosa, which is the one which we commonly see. Xeroderma pigment. So you can specifically say no evidence of any xeroderma pigmentosa in the body. Okay.
Coming to the ocular examination, let me first start with the ocular examination of the left eye. Best corrected visual acuity, distribution 6, near vision, N6 to diopter sphere, color vision normal, field of vision by confrontation, full in all directions, eyebrows normal, orbit examination, no proptosis, dystopia, or any other palpable mass, extraocular movements, full in all directions of gaze. This is the picture. Coming to the examination of the lower lid swelling, two distinct swellings located at medial 2/3 of the inferior lower lid of size 12 millimeter into 6 millimeter and 8 millimeter into 5 millimeter seen, irregular in shape, variably black to brown pigmented, central depression with surrounding pearly rollout edges, ulcerated with crusting, crescent of the swelling and no bleeding noted. It has a well-defined borders, firm in consistency, superficial telangiectatic vessels are seen, widening, thickening and hyperpigmentation of the eyelid margin with loss of eyelashes seen, notching, lower lid notching noted, no fixation to tarsus or orbital rim, no sensory alterations present along the lower lid area or face, no tenderness present over the swelling and surrounding skin, no ptosis or facial weakness. Coming to the examination of the ophthalmic examination, plica and chirangular normal, upper and lower tarsal conjunctiva normal, inferior and superior conjunctival fornices normal, skin sclera normal and no swelling seen, cornea clear, anterior chamber quiet Van Herrick's grade 4, iris normal color pattern, lens clear, pupil 3 millimeter round and central, direct and consensual reflexes were brisk. Fundus examination using indirect microscopy, indirect ophthalmoscopy with 20D lens, media clear, disc and vessels seen normally, neuroretinal rim even and pink, CD ratio 0.3, foveal reflex present, visualized background retina within normal limits, intraocular pressure with applanation tonometry 12 millimeters of mercury, nasolacrimal duct free flow.
Can you just go to the clinical picture once? No, before.
Madam.
Okay, yeah, fine. So what is the relationship to the punctum?
Punctum is
you said nasolacrimal duct is free flow. Punctum can you see, or punctum closed?
punctum was seen to be compressed, closed.
So punctal stenosis.
But in nasolacrimal duct, there was free flow.
Okay, so you mean there is a punctal stenosis. I cannot see punctum in this also. Anyway. So now, what's the relationship to the canthus? So these are all very, very important when you describe a lid tumor. You have to see the relationship to the important anatomical landmarks. So punctum appears stenosed. Canthus, the tumor is stopping short at the canthus, no? Near the canthus. You said plica and caruncle is free from the tumor, right?
Yes, ma'am.
Okay. And there is no tarsal conjunctival involvement also.
Yes, ma'am.
Okay. Okay, fine. Rest all you have mentioned. Then there is a mild ectropion too.
Yes.
Yeah. Okay, now you can proceed.
Coming to the ocular examination of the right eye, best corrected visual acuity, distant vision 6.6, near vision N6 with 2 diopter sphere, color vision normal, field of vision by confrontation, full in all directions, eyebrows normal, orbit examination of proptosis, dystopia or any other palpable mass, extraocular movements, full in all directions of gaze, examination of the upper lid, a small round elevated well circumscribed swelling of size 3 into 3 millimeter located in the medial aspect of upper lid just above the medial canthus, hypopigmented with a central umbilication, and 1.5 into 1.5 millimeter sized brown pigmented round elevated swelling noted in the upper lid, 6 millimeter from the eyelid margin. Ophthalmic examination, no involvement of plica and caruncle, conjunctiva appears normal, superior and inferior conjunctival fornices normal, sclera normal, no swelling seen, cornea clear, anterior chamber quiet, iris normal color pattern, lens clear, pupil 3 millimeter round and central, direct and consensual reflexes, where pupillary reflexes were brisk, Fundus examination using direct ophthalmoscopy, media clear, disc and vessel seen normally, neuroretinal rim even and thin, cup disc ratio of 0.3, foveal reflex present, visualize background retina within normal limits, intraocular pressure with applanation tonometer, indicators of mercury, nasolacrimal duct free flow.
Okay, just wait. So in this tumor, how will you assess the fixity to the underlying structures? I think you had told somewhere there is no fixity to the underlying structures. How will you assess the tumor fixity in this case?
Tumor was mobile.
Yeah, one is when you palpate, it is freely mobile. Any other? If it is fixed, how will you know? One, it is not mobile. Second,
By everting the lid. If the
eversion will be difficult. Very difficult to see the posterior surface if it is fixed to the underlying structures. Third thing is ask the patient to open the mouth.
okay.
Okay, then you can see there is pulling down. You can see that pulling down of the lid. It is because it is usually the lid will not move when you open the mouth. Okay, and you can see assess the scarring of the, because it causes cicatrization. You can assess the scarring by opening the mouth and see. Okay.
Okay.
Okay, then summarize.
Coming to the summary, 65-year-old female with known case of hypertension and dyslipidemia presented with a history of swelling below left lower lid noticed 3 years back, which rapidly progressed to present size of the past 6 months. On examination, left lower lid shows 2 distinct swellings located at medial 2/3 of the inferior lower lid, or lower lid of size 12 millimeter into 6 millimeter and 8 millimeter into 5 millimeter, irregular in shape, variably black to brown pigmented, central depression with surrounding pearly rollout edges seen, ulcerated area with crusting present in one of the swelling, well-defined borders, firm in consistency, superficial telangiectatic vessels were present, widening, thickening, and hyperpigmentation of the lid margin with loss of eyelashes present. Vision, left is 6/6, anterior segment and posterior segment examination within normal limits. On examination of the right eye, a small, round, elevated, well-circumscribed swelling of size 3 to 3 millimeter located in the medial aspect of upper eyelid, just above the medial canthus, hypopigmented with central umbilication and a 1.5 into 1.5 millimeter sized brown pigmented round elevated swelling noted in the upper lid, 6 millimeter from the eyelid margin. Vision in the right eye, 6/6, anterior and posterior segment examination was within normal.
Coming to the diagnosis.
Differential diagnosis in the left eye are basal cell carcinoma, nodulo-ulcerative type, malignant melanoma, or it could be squamous cell carcinoma. Differential diagnosis in the right eye, sebaceous cyst, nevus papilloma, or molluscum contagious.
Okay. So you are saying you have put the first diagnosis as basal cell carcinoma, right? So why did you say this is basal cell carcinoma? Why I'm telling it is malignant melanoma. So how will you contradict me, or how will you?
Based on the location, basal cell carcinoma most commonly seen in the lower lid medial canthus. Also,
okay. So when you're asked about the what is your why you say it is basal cell carcinoma, always start from the history. So from the history, what do you think? Is it basal cell carcinoma or melanoma?
Basal cell carcinoma, because if it was malignant melanoma, then predisposing nevus would be present, and also more aggressive in nature.
So that's a key point. If it was melanoma, the patient will usually give a history of mole that is very long standing, like 20 years, 30 years. But did you ask how that small swelling, what was the initial color of that small swelling in this case?
We told initially it was not this much pigmented.
Okay. Okay, fine. So from the history, that is the one differentiating feature, more in favor of basal cell. So now come to the findings.
From the findings, basal cell carcinoma will be more of dry looking with well-defined margins.
Okay.
Malignant melanoma would be more, there will be more discharge and vascularization, and it is more aggressive, so margins would be more ill-defined.
Clinically, there is a characteristic picture of basal cell carcinoma. So what is it called? What is the edges?
Edges are rolled out.
Yeah, so it's called rodent ulcer. Yeah. So then location, it is in most common in the lower lid and medial 1/3. Why? In any idea why basal cell is more common in medial 1/3 lower lid?
No,
Huh? Now,
no,
you can think about it, like, what is the major reason? Primarily ultraviolet radiation, right? So compared to the upper lid, lower lid is more exposed to sunlight. Why upper lid is less exposed? It is covered by eyebrow, but lower lid is more exposed. Okay. Then why it is in the lower lid, it is more common in medial 1/3? Any idea? Why not it is lateral 1/3? That is my question. Okay, the one reason, one explanation given is, see, there are some toxic substances are also responsible for basal cell carcinoma. So through the tears, that is the area where tear is more in contact with the medial 1/3 rather than the lateral 1/3.
Okay.
So that is also some projected reason for why medial 1/3 is more common in basal cell carcinoma. One is sunlight, second is this toxic substances. Okay. So what is the other differentiating feature? Melanoma versus
vascularization.
no, melanoma sometimes lid can extend to the conjunctiva very often. But basal cell carcinoma in very aggressive variants or in very long-standing cases, it extends to the conjunctiva. Okay. Then what about squamous cell carcinoma in this case?
Squamous cell carcinoma, it will be less pigmented.
Yeah. It is usually very rarely, like, not at all pigmented most of the time. That's the most common, most important differentiating feature. Then squamous cell carcinoma is more common in
White.
yeah, more common in whites. Okay. Is this sebaceous gland carcinoma?
Then tarsal plate, it will be more adjacent to the tarsal plate.
No. See, sebaceous gland carcinoma, right away you can say this is not a sebaceous gland carcinoma. Reasons. One, from where sebaceous gland carcinoma arises?
From the meibomian gland.
Yeah. So meibomian gland orifices should be closed. Okay. It can have tarsal involvement. Okay. Then it is more common in upper lid or lower lid.
Upper lid.
Why? Which lid has more meibomian gland orifices? No, it didn't read. Upper lid. Upper lid. So it's more common in upper lid. SGC. Okay. So now, what all things would you like to do in this case?
First of all, blood routine examination has to be done in metastatic workup. Ultrasound of the abdomen, chest X-ray, CT head has to be done to rule out metastasis.
Lymph nodes you have checked, no? So ultrasound of, clinically there is no lymph nodes. What's the pattern of metastasis in basal cell carcinoma?
locally advancing tumor.
It's a locally aggressive tumor. So what are things you have done? CT scan, ultrasound abdomen, and ultrasound neck just for documentation. Then routine blood, viral markers, etc. So how will you proceed in this case?
In this case, since the diagnosis of malignancy was almost certain, we'll proceed with wide excision with almost 2 millimeter, 4 millimeter margin inside and outside of the tumor. I mean, outside the skin surface and the full thickness tumor excision has to be done with lid reconstruction.
Okay, so how will you counsel the patient before you proceed with surgery in this case? What all things will you tell the patient?
Chance of recurrence has to be
recurrence. If you do a good wide excision, 4 millimeter or 5 millimeter, recurrence is like, if you do good surgical clearance, recurrence is very low, but still you can say as a last before that.
Then the patient should be counseled about the wide defect that will be produced after the excision of the tumor.
No, that we are going to reconstruct, no? No. That we will reconstruct. See, you are the surgeon and you have posted the patient for surgery tomorrow. In the pre-operative counseling, what all things will you tell the patient? So, what is the location of the tumor in this case?
In medial canthus, so sense of epiphora.
Yes, that is very, very important. So, in this case, we have to sacrifice the lower canaliculus. Okay, so we have to tell the patient that you will have watering post-surgery. Then second,
then ectropion, entropion.
So little bit of lid malpositions. Sometimes the lid can have little ectropion. So lid malpositions, you have to counsel the patient. Third,
exposure, corneal exposure, and
then regarding the appearance, cosmetic appearance, you have to tell the patient. So after surgery, we are going to reconstruct this area. It might not exactly look like the other eye, but more or less it looks like the other eye. So you have to tell them regarding the post-op appearance. Fourth, follow-ups. Recurrence, you can say. Okay, fourth is recurrence. Then follow-up. How will you follow up? Okay, that we will come later. So these are the few things that you have to tell the patient before surgery. Okay, now you are posted for surgery. What exactly you are going to do in this case? Can you just go back to the just put that clinical picture? Yeah, okay. So now 4 millimeter wide excision, no? So can you just draw that 4 millimeter with your cursor?
Madam, I have a picture name.
Okay. You then put the picture. Right.
Madam,
yeah.
Skin markings are first made.
Yeah. Then you excised you took 4 millimeter, right? Okay. So 4 millimeter frozen section or just direct closure. Ideally, all the tumors needs frozen section. Then again depends on the availability. Okay.
Yes, ma'am.
So how did you reconstruct that?
Here frozen section was not done.
Okay, no problem.
Tumor was removed and reconstruction after removal of tumor. This is the picture of
Okay.
the defect. Then, since it is involving more than 75% of the lower lid,
Yeah.
and also it is a full thickness defect, we want to reconstruct the posterior lamella and also the anterior lamellae. For reconstructing the posterior lamellae, mucosal flap is taken from the mouth, and it was marked, and it is the picture after reconstructing the posterior lamellae. Then for reconstructing the anterior lamellae, mustard this rotation, cheek rotation flap was done.
Okay. Yeah, that is actually one option in reconstructing this. Any other options can you think of in this case?
For reconstructing the posterior lamellae,
Yeah.
tarsoconjunctival flap from the upper lid.
What is the name of that flap?
Fuchs procedure.
Yeah. So you can use Fuchs for the posterior lamella, and for the anterior lamella,
It could be rotation flaps or myocutaneous flap,
yeah.
transposition flaps.
Okay. In this area, which flap will you use? You can go back to the clinical picture. I mean that yeah, that excised picture is fine. Yeah. Next picture. Yeah. So which flap can you use for reconstructing this anterior lamella in this area? Can you think of something? Can we lift something from here?
From forehead flap.
Forehead will be very difficult. Forehead for upper lid it is fine. For the lower lid, actually you can use this nasojugal flap. You can lift like this and you can put it like this.
Okay.
Okay, that is also one option. Okay.
Okay.
Then how did you follow up this patient, or what is the regular follow up in tumors? How frequently, for how long?
First follow up after 2 weeks. After the 2 weeks. Initially, patient was in the IP care for almost 1 week, and daily assessment of the wound was done for exposure, for looking wound discharge, exposure.
Okay, for a tumors, we actually follow, there is a tumor follow-up guideline given for the sebaceous gland. So that is almost applicable to all the other tumors also. So initially 3 months for 1 year, then 6 months for 4 years, and then yearly thereafter. So during the follow-up, what all things will you look for?
Initial period, we look for the wound discharge, exposure, then later on entropion, ectropion, corneal ulcers if developing, then flap necrosis.
Most important thing is look for any local recurrence. Okay. Then any regional lymph nodes, especially preauricular and cervical. So in this, what was the histopathology? What about the margins?
Histopathology came to be basal cell carcinoma, and the lateral margin was tumor positive. So patient was sent for radiotherapy.
Oh, okay. What was the differentiation of the tumor? Like, do you have the histopathology report? Any in histopathology, what all things will you look for when you treat a tumor? One, type of the tumor. Okay. Second, is it poorly differentiated or well differentiated? Basically, it carries, it determines the prognosis. Poorly differentiated tumors usually will have poor prognosis, and you have to be very careful. Always check the area, any area of any recurrence, etc. Then look for any perineural invasion or lymphovascular invasion. Why?
It can enter into the metastasis into the organ.
Yes. See, some of the basal cell carcinoma, usually some variants are very aggressive. They can have perineural invasion as well as lymphovascular invasion. So if there is a perineural invasion, what you will do? You have to give a prophylactic radiation. Okay. I mean, what about is there anything such something like that in this case, or it is just basal cell carcinoma?
Perineural invasion was
Not there. Lymphovascular invasion not there.
only the
Is there any role for radiotherapy in the so what did she underwent radiation, or
she's now undergoing radiations.
have they given radiation?
Started
Okay. Okay, fine. So when will you start radiation in this case? Immediately, 1 week. Once the wound is once the wound is completely healed, only you can start the radiation. Otherwise, what will happen?
plaque necrosis.
Yes, you can get plaque necrosis and wound dehiscence, then exposure, etc. So usually we start radiation after 4 to 6 weeks once the wound is completely healed. Okay. What happened to the other eye lesions?
Other eye lesion was
Left alone.
it came as epidermal cyst.
Okay. Hello.
Madam,
What are the types of basal cell carcinoma you know, and what type is this?
common types are most common is nodular type, followed by superficial pigmented cystic morphia or sclerosing type. This is a nodular type.
Okay. Which is having the worst prognosis and which is having the good prognosis?
Nodular is having a good prognosis.
So this is a good prognosis. This variant, the one you are having, this patient is having a good prognosis. Worst prognosis?
Sclerosing.
So this patient has been sent for radiation. Any other treatment option in the margins are positive?
Madam, chemotherapy, cryotherapy.
Cryotherapy can be done. Then you have to reopen the wound, or you can give cryo even without reopening the wound. Any other options? Have you heard about imiquimod? Imiquimod, IMIQO. No, not heard of. It's a topical immunomodulator given in basal cell carcinoma, but basically it is given in superficial spreading. This is actually nodular ulcerative. Yeah. So superficial spreading type. That cream is given 5 days a week. You can continue for at least 3 to 6 months. When BCC is very wide and sometimes very difficult to get margin clearance, you can use topical imiquimod. Any other? What is the latest in the management of basal cell carcinoma? Suppose this patient is bedridden and not willing for anything, or not amenable to surgery, very difficult to mobilize the patient. So in that case, anything recent, even though it is very costly, but those who can afford can afford. That's it. What is the recent in the management of BCC? Have you heard about vismodegib? Huh?
We have heard plan.
Yeah. So what is it? It's a hedgehog inhibitor. These are all latest. There are some receptors inhibitors. Now everything is based on genetics and receptors. So there is a pathway involved in the tumorigenesis, that is hedgehog pathway. So this vismodegib is available in India also, and it can be given, but it is very expensive, and you have to continue it for a long term. So that is the disadvantage of this treatment. But actually, it is indicated in extensive BCC, not available to surgery, or the patient is very sick who cannot undergo any types of surgery, and it gives you very good result also. I think.
Me, can I add something?
Yes, sir. Yes, madam.
This regarding a good presentation, but regarding some point in the clinical findings, we say that it is not fixed to the underlying structures. Tarsal plate is free, but the pigmentation is extending to the lid margin. The punctum is compressed, and there is loss of lashes. And in the picture, there is a notching of the lid margin. So in such a clinical picture, it is extremely unlikely that the tarsal plate is not involved. That is one thing. Then another thing is about her visual acuity. You said the best corrected visual acuity is 6.6. Then near vision N6 with +2. When you say best corrected visual acuity, this is for distant vision as well as for the near vision. So you can very well say it is 6.6 and 6.
Yeah.
You don't have to add the near vision addition. If you are adding the near vision addition, you add the near distant vision addition also.
Yeah.
And also it is always better, it looks nicer. And in clinically also it is usually done is intraocular pressure and the visual acuity of both eyes are presented together.
Okay,
I don't know
ma'am.
whether the recent practice is one eye then the other eye. But in clinical practice, we never go with the one eye vision and then one eye intraocular pressure. So in a presentation also, it sounds nicer if both are given together.
Okay, ma'am.
Okay.
I also think Shiba made a good presentation. But only thing, no, when you have gotten swelling in the medial canthus lower lid, I think the relation to the punctum could have been, because I think in your initial thing, how it is related to, because medial canthus when you surgically, anyway, the treatment is surgical, so the relation to the punctum should have been mentioned. I don't think that was only when the guru asked that you mentioned that, is it? Or was it mentioned earlier? No.
It was not included, sir.
Yes, because no, the relation to the punctum should have been mentioned. Otherwise, her presentation was good.
Thank you, sir.
Okay,
Thank
okay,
you, sir.
okay. You can continue, Marian.
I want input from others also.
Marian, you are telling something regarding the recent trends, no?
Yeah, I told her.
Yes, you can. I think you can continue with that.
Yeah. Anybody wants to add anything on this? So, no, see, for doing this, you did, which flap you have done?
Cheek rotation flap, ma'am.
Oh, Mustardis cheek. What's the name of that?
Mustardis cheek.
Yeah, Mustardis cheek rotation flap. So, which are the? How did you dissect? You assisted or?
Assisted, ma'am.
What is the? What exactly you show? You have shown the incision. So, to what extent will you go? And what's the most important structure you have to take care when you do mustard cheek rotation?
Facial nerve.
Yeah, branches of the facial
Branches
of the facial nerve. Yeah, okay.
Edges are undermined
Fine.
to get a tension-free approximation.
Okay. What was the extent? I mean, lacrimal sac. What is the relation to the lacrimal sac? It was kept intact, no? Or
It was kept intact.
suppose the lacrimal sac was involved, what would have been your management? Suppose when you measure the 4 millimeter, it was, will you do DCT or will you leave alone or what will you do?
I'm not sure.
No, see, what are the indications for DCT? Tell me the indications for DCT. Regular, not related to this. What are the indications for DCT?
Chronic dacrocystitis.
I mean, you cannot say first it has chronic dacrocystitis. Chronic dacrocystitis, we do DCR first. What are the absolute indications for DCT? One is tumors, no. Yeah, tumors. Second. Okay, anyway, this is not NLD. So suppose the lacrimal sac was found involved in this case, you have to do a DCT. So that is why we have to always tell the patient that like there will be epi for a post-op.
Okay.
Yeah, okay. Laterally, 4 millimeters, still the margins were positive, right? You have taken 4 millimeter and still the margins were positive, right? Okay. So that shows the importance of frozen section. The regularly we take 4 millimeter and suppose the margins are positive, again you have to take another 4 millimeter. So the total comes to around from the edge of the tumor, it will be total 8 millimeter. Yeah, 8 millimeter.
Then your plan of reconstruction will be different, is it, Marian?
Yeah, for
Because,
me,
yeah,
for
8
me,
millimeters, no.
Yeah, 8 millimeters almost total lid will go.
Ah,
I mean,
exactly.
Yeah, more or less.
But in this case, she has been sent for radiation, and usually sacrificing the compromise of not removing the 4 millimeters and post-op radiotherapy. Do you think that is also worthwhile?
I will compromise the lid only because radiation is like, I mean, it's not very sensitive to radiation actually.
Yes.
Yeah. So ideally, I will reopen the wound and excise under 4 millimeter.
And I suppose there's no facility for frozen section, and we have come with this result. No, then again, then at the second sitting, you will excise again 4 millimeters.
Yes. Because in what we do is when we are in doubt, we just leave the defect open. Keep a frost suture or do a temporary tarsography and wait for the permanent section.
How many days can you wait? How many days can you wait?
5 days. Actually, the pathologist will give you the result in 5 days time. So call the patient after 5 days and then reconstruct.
Oh, till that time we can wait, no?
Yeah, bandage. We can keep a tarsography and bandage. Even sometimes frozen section comes very tricky. The pathologist will say,
yes. Frozen sections you can't probably be 100% definite.
Yes, sir.
And if it comes as involved, no. If it comes as involved, okay, no problem.
Yeah, no problem.
No problem. Otherwise, and the negative doesn't really rule out.
Yes. Someday they will give you query involved, like we are not sure.
Exactly. Yes.
So in that case, we will wait. Just do a tarsography, close the wound. I mean, just temporarily close the wound with 1 or 2 sutures, put a bandage, start antibiotics, call the patient after 5 days or 6 days, just, and then reconstruct. Otherwise, you will get recurrence. I mean, that's all from my side.
I think Shiva had a good concept
Yeah.
of the anatomy, posterior lamella reconstruction, anti-lamella reconstruction. I think she has read well.
Yeah.
Yes, read well, because normally, in these things, anatomy is very important. Anatomy is always important, but especially in these things, it's very important. I think she has prepared well.
Surgery was under GA or LA?
Surgery was under general anesthesia.
Okay, good presentation.
Thank you.
Probably you can summarize, Marian.
Yeah, yes, sir. Yes, sir. Yeah. So today we had an elderly lady with basal cell carcinoma involving the middle 1/3 of the lid. So we have discussed how to take a history. Very important to ask the history of radiation, immunosuppressants, then history of any skin, nevi. Then in the examination, important landmarks. Always assess the tumor in relation to the important landmarks. One. Second, assess whether it is benign or malignant. So in this case, she had all the clear-cut features of malignancy, like loss of lashes, irregular surface, telangiectasia, then rapid history, also rapid increase in size. Then relation to the punctum, medial canthus, then involvement. You have to mention the relationship to the tarsal conjunctiva, fornix, etc. Then management. So the diagnosis was almost clear-cut, basal cell carcinoma, and the management also wide excision with the frozen section if available, or with the 4 mm margin and reconstruction. Reconstruction also we have seen various options. So in this case, we have reconstructed with the mucous membrane graft for the posterior lamella and anterior lamella with Mustardi's cheek rotation. Other options also we have seen. Then non-surgical options, that is topical imiquimod cream, that's also available for us. Then the recent advances is like Bismuth, oral Bismuth digit. It's very costly, but those who can afford can afford. So basal cell carcinoma in a nutshell. Then pathological clinical variants. Then pathological risk factors like lymphovascular invasion, perineural invasion, differentiation of the tumor, etc. We have to keep in mind. It's all applicable in all the tumors, actually. Then follow-up of the patient. Then for in each follow-up visit, you have to look for local recurrence, regional lymph nodes, then any complications related to the surgery, complications related to the scarring, like lid malpositions. And you have to address accordingly. I think we have summarized, and we have gone through almost all the aspects. Then preoperative counseling, that is very important, especially when there is post-op watering. Majority of the patients like very irritated most of the time. So I think we have discussed everything in detail, and thank Dr. Shiva for her excellent presentation, and she prepared also very well. I thank all the RIO faculty members also helping out. Thank you.
PSC madam, എന്തെങ്കിലും പറയാനുണ്ടോ madam? Madam leave ചെയ്തോ?
I think madam
പോയെന്ന് തോന്നുന്നല്ലേ? So thank you, Marian, for that recent things other than the ones which we usually talk about.
Yeah. Thank you, sir.
Thank you.
Thank you, madam.
Thank you.
Thank you, sir.